Hello, and thank you for taking the time out of your evening to join us for this Introduction to IVF webinar with Professor Charles Kingsland. Following the presentation, Professor Kingsland will be responding to your questions. You can submit these at any time during this evening's webinar via the Q&A panel on the right-hand side of your screen. I will now hand over to Professor Charles Kingsland.
Thanks, Sam. Hello, everybody. It's not often that I get an introduction. Normally, I have to do it myself, but it's a few months since I've done one of these introduction to IVFs. So, and Sam is one of our new colleagues. So, welcome to Care Fertility, Sam. So, in the next 30 minutes or so, I'm going to take you through the rudiments of IVF, what it's all about, why you might need it, what are the implications, and what are the pitfalls. As Sam said, I'm around at the end. I can answer questions, and if you submit your questions, we have some of our team. Georgia is on the line to hopefully answer as we go along, and if not, we can always get back to you at the end. So, IVF. As I said to you before, I'm the Chief Medical Officer at Care Fertility. We have, I think it's 15 laboratories and 25 clinics. We do about 12,000 cycles of IVF per year, which makes us the largest IVF group in the country. I actually have been doing IVF for nearly over 35 years now, and I started in Bourne Hall in London, in Cambridge, working with Professor Robert Edwards, who was the first scientist to work in IVF, and then I moved up to Liverpool in the late 1980s and set up a clinic in the National Health Service, the Hewitt Centre. Then I moved to Care in 2018. So let's go on to the first slide. Sam, could you just help me with the first slide, please? Thank you. So here are our clinics. We are now an international company. As I said before, we've got clinics all over the UK. I think we're up to about 15 laboratories, and you can see on the map we have a really good spread. One of our recent additions is in the clinic in the southwest in Plymouth. Our largest clinic is in Leeds, but they're all over. And we also have a clinic in Dublin. We have 4 clinics in Spain, and we have our first clinic in the United States, which we acquired a couple of years ago in North Carolina, in a large city called Charlotte. Next slide, please. So, many of you who've been trying for a baby will have and so far have been unsuccessful, might have phoned your doctor or been to a nurse for advice as to what might be wrong. Some cases there's very little wrong, and you just need to maybe try a little bit longer. Sometimes there's no explanation for why you're having difficulty achieving your pregnancy, but it's essential that we get the right diagnosis, so that if you get the right diagnosis, then we know what the best treatment for you is to help you achieve the family that you want. Next slide, please. So there are lots of tests you can do, but the 3 main important ones, you need to answer 3 questions. 1, for the female, have I got eggs in my ovaries? 2, are all my bits in the right place? Do I have everything down, 1 of everything up the middle and 2 of everything down the sides? And 3, are the sperm that are deposited in my vagina, if you're a heterosexual couple, have the ability to swim from my vagina up into my egg? Bearing in mind that for a sperm to swim from the vagina to the egg is the equivalent of a man swimming from Liverpool to New York. It could be Southampton, but because I live in Liverpool, I normally say Liverpool. And so the 3 tests we do is an AMH blood test. It's a simple blood test, and AMH stands for anti-Mullerian hormone. Anti-Mullerian hormone is a hormone that's produced by your eggs. The more eggs you've got, the more AMH you've got. So it gives you an impression of the quantity of eggs, not the quality of your eggs. The quality of your eggs is dependent on a lot of different things, but most importantly, your age. The difference between boys and girls is that girls are are egg warehouses. Girls have all their eggs in their ovaries on the day they're born. You can't make eggs. You can't make them better. They only deteriorate over time. Whereas boys are sperm factories. We make sperm every single day of the week. Some days we're good at it. Some days we're bad at it. As we get older, we're not as good at making sperm, but we can still make sperm up until the day we die. So sometimes it might be better if you've got a low AMH and be 25 than have a high AMH and be 40, if you see what I mean. So quantity of eggs, the AMH test shows you, not necessarily the quality. But it's nice to have a few. So an AMH blood test will tell us how many eggs you've got. A pelvic ultrasound will give us an impression as to what the health and the status of the female's pelvis is. So a simple ultrasound scan will give us a really good idea of what's going on and to make sure that everything is in the right place. For the men, we need to do a semen analysis. That's an assessment of your sperm, and we have a look at a sample of sperm under the microscope. And there are three things we want to know: how many sperm there are, whether they're swimming in front crawl, backstroke, doggy paddle, and how many are normal. And surprisingly, we don't, only 5% of sperm need to be normal for a normal sperm count. Us males, 95% of the sperm we produce are abnormal, but we only need 5%. They need at least 40% need to be doing front crawl towards the New Brighton Lighthouse as opposed to backstroke towards Birkenhead. So we want about 40% to be swimming quickly in the right direction. And we need 20 million sperm per mil of fluid, which gives us a normal count. Again, it doesn't tell us whether they're fertile or not, but we know if you hit those targets, 5% normal, 40% swimming front crawl, 20 million per mil, you've got a good sperm count. And they're the three tests. And on the basis of those tests, we can make pretty much most of the diagnoses that we need. Next slide, please, Sam. Those tests will be combined with your consultation. Obviously, what we need to do is to know about how long you've been trying, what sort of relationship you're in. Are you a single person wanting a family? Are you in a same-sex relationship? Are you in a heterosexual relationship? How long you've been trying? Have you got any previous illnesses that might signify that you might have a problem conceiving? For example, have you had pelvic infections? Have you got endometriosis? Do you have polycystic ovarian syndrome? These are all questions that we need to ask. How often do you have an opportunity to try and get pregnant? Are your periods regular or not? So as an example, if a female has regular periods, there's an 85% chance that she's releasing an egg. If she has irregular periods, then that chance of releasing an egg predictably goes down to 15%. It doesn't mean to say that you haven't got eggs. It just means that you're probably not releasing them at the right time. And if you're not releasing them, then they can't get fertilized. But all these things are important as part of your consultation. And as I said before, the most important thing is how old are you? Next slide, please. So, on the basis of your tests and your consultation, we will decide with you what is the best treatment to get you pregnant as quickly as possible and as cheaply as possible if you do not get access to NHS treatment. And we know that post-COVID, that that there is a real pressure on not only hospital services, but in particular women's services, and of women's services, the most pressure is on fertility services. So we know now that there can be inordinate waiting times for NHS treatment. So it might be that you decide that you want to pay for your treatment, or it might be you've got time to wait. Everybody's different, and there are different waiting lists in different regions. However, tonight we're going to talk about IVF. So I'm going to go through the IVF process. If you've had your diagnosis, say you've got blocked fallopian tubes, or the male partner's got a low sperm count, or you're producing eggs, you're releasing eggs, everything seems to be normal, so you've got unexplained infertility, you've been trying for a long time, IVF may be the treatment for you. And the IVF process has not changed over 30 years much. It's still the same process. And stage one involves stimulating your ovaries so that instead of producing one egg, we produce as many eggs as we safely can. And we stimulate your ovaries using a natural hormone that's normally produced by your body, but we use a much higher dose, so that instead of under normal circumstances being used to grow one egg, we want to grow 6, 7, 8, 9, 10, 11, 12 eggs if we can. And we start injections at the beginning of your beginning of your cycle on a daily basis, and we monitor the growth of your eggs, which grow in follicles. They're little sacs of fluid that the egg grows in. Now, this is a series of pictures showing the injections. The injections, we teach you how to give them, either you or your partner, and you load the fluid, the hormone, into a syringe with a very fine needle, and then you inject it into the wall of your tummy, or it could be into the muscle of your leg, whatever's most convenient. But you don't have to worry, we'll teach you how to do it. There's loads of information on the website, and if you have any difficulty, our nurses in the clinic will show you how to do it. And you need to do these injections on a daily basis at around about the same time. Next slide, please. This is the monitoring, and this is Rima, our senior consultant from Birmingham, demonstrating an ultrasound scan. The ultrasound scan will measure the growth of the follicles in which the eggs grow. And we normally do a baseline scan, which is on at the beginning of the cycle, and then a scan at the end of the stimulation, which is normally about day 8 or day 9. You don't necessarily need scans in between. That's a bit like, you know, when you're baking a cake, you put all the ingredients in the oven and then you bake it for an hour or so. You don't need to keep looking at it to see whether it's rising or not, because there's nothing you can do that will change the contents of the cake. You just have to let it bake and see what comes out at the end. But hopefully 95 times out of 100 we'll get the dosage right for you first time. So the scanning is a vaginal scan. The probe, which is the size of a thick pencil, is placed into the vagina so that we can get a really good view of your ovaries, which is where the follicles are growing, and they contain the eggs. Next slide, please. Once the follicles are ripe, normally we say the key is that they grow to about 20 millimeters. That's 2 centimeters in diameter. So when the leading follicles are 2 centimeters in diameter, so a good indicator that the eggs that are contained within the follicles are ready for collection. Now, to finish off the growth and maturing process, we will give you what we call a late night trigger injection. This is an injection that finishes off, sort of polishes the eggs, if you like, and then 36 hours after that injection, we program your egg collection. We know it has to be 36 hours because if we leave it for 38 or 40 hours, then those eggs will probably pop. So we need to get you after 36 hours after the injection in to get your eggs collected. So the late night injection is always programmed for 36 hours before your intended egg collection. The egg collection is a simple procedure. It's done under sedation. You don't need to be anesthetized, and we put a little needle with the help of an ultrasound probe from and through the top of the vagina into the ovary and into the follicles. And then we suck out the fluid in the follicle and give it to our embryologist, who then looks for the eggs. Next slide, please. So the egg collection process takes about 10 to 15 minutes. It's usually fairly pain-free. It's not the most comfortable thing you've had in the world, but it shouldn't be excessively uncomfortable. As I said, you are sedated, and then after the egg collection, you'll get over the sedation, have a cup of tea, have a wee, and then you're ready to go home, usually about 2 hours after your egg collection. In the meantime, if you're in a heterosexual relationship, the sperm, the male partner has been asked to produce a sample of sperm, and then we can look at the sperm under the microscope, and our embryology colleagues will prepare the sperm. And I think if, Sam, if you've got a video of this, you can see the sperm swimming around. There they are. Clever little devils, aren't they? And what we do is we monitor the sperm, and we want to pick the best sperm that are swimming in the right direction. And I know it sounds a bit strange, but we also look at things like how they're swimming, whether their head's moving too much or whether the head looks a bit dodgy. You can see one in the middle there. He don't know where he's going, does he? Yeah, the two on the side at 3 o'clock, they're going backwards and forward there. Yeah, we'll have those two. Okay, next slide, please. Then what happens? We get the eggs at the embryologist, and this is where the clever stuff starts. And if the sperm count is normal, we will incubate one egg with 100,000 sperm. Sometimes, however, if we haven't got 100,000 sperm, we're not confident that the sperm will fertilize the egg themselves. So we'll take one sperm and inject it straight into the egg. So instead of just putting them round the egg and leave them to get on with it, we'll take one sperm and inject it into the egg. And that is called ICSI, intracytoplasmic sperm injection. And although many of you listening may not be 35 or 40, the first ICSI that I remember that was done in the UK was 1996, which to me wasn't a long time ago. Now, before that, men with poor sperm counts, was very little we could do for them. Nowadays, I've seen men father children when they haven't had 50 million sperm or 5 million or 5,000, they've had 5. You only need one good sperm to make a baby, and that has been a brilliant innovation that's occurred in IVF. And indeed, in the United States of America, 100% of couples undergo ICSI. We don't leave anything to chance. There are pros and cons for that, but if you've got a good sperm count, we do IVF. If you've not got a good sperm count, we do ICSI. Next slide, please. So here's our embryologist looking at looking for the eggs and then preparing the sperm. That slide in the middle is a needle. Oh, what is it? Oh yeah, that's a needle injecting a sperm into the egg. Now that needle is the size of a human hair. It's amazing what you can do these days with in our laboratory, and that is the process called ICSI. Next slide, please. So what happens then is once we've fertilized the egg, either with IVF or ICSI. We put them in an incubator, we close the lid, and then we leave them. We monitor the process by videoing the growth and development of the embryos. And this is very clever. Many years ago, we didn't have this innovation called time-lapse technology. The only way we could grow and develop the embryos was to look at them. So on the first day, we'd get them out of the incubator, look at them down the microscope and say, oh, they've fertilized, and we put them away. Then the following day, we'd take them out again and have a look to see whether they've grown any further. And we could only culture embryos up to 2 days old, because the culture medium, we didn't have the technology or the ability to culture embryos in a laboratory for longer than 48 hours. So we used to put the embryos back at age 48 hours. Nowadays, we can grow embryos for 5 days. So, and not only that, we don't have to look at them under the microscope anymore, keep taking them in and out of the incubator. We actually video them. And every 10 minutes, we take a photograph so that we can plot the growth and development of those embryos every 10 minutes. That's called time-lapse technology. Next slide, please. Now, what we've developed at Care is we can compare the growth of and development of our embryos against hundreds and hundreds of thousands of embryo pictures that we've taken over the last 15-20 years of embryos that grow into babies and embryos that don't grow into babies. So at the end of the 5 days, we have got we can grade the embryos very, very accurately based on their what we call morphology, what they look like, and give you an idea as to whether those embryos are normal or not. We've also and we call that Care Maps. But over the past 2 years, we also have developed a process using artificial intelligence where we can super duper, I'm going to say super duper because I don't understand AI, assess these embryos, and we call that Care Maps AI. And all our patients are offered Care Maps to check the accuracy of the grading of those embryos. In some cases, that gives us an impression based on what they look like, how they've grown, how quickly they've divided. But in some cases, if we want extra information, we can do something called pre-implantation genetic assessment, where we take a few cells of the blastocyst. A blastocyst is an embryo that's grown for 5 days. And we take 4 or 5 cells from the blastocyst, and we're showing that in the last slide there, PGTA, and we can actually look at the chromosomes in those cells that we've extracted. Now, a blastocyst has got about 100 cells. We take 5 cells, and at that stage, when they're 5 days old, it's perfectly safe because the blastocyst can regrow those cells quite safely. So we take the cells and look at them, and then we can tell whether that embryo is genetically normal or not. Now, embryos created in laboratory are exactly the same genetically as embryos created in the woman's body. There's nothing that we do in the laboratory or in IVF that makes embryos abnormal or any different to embryos that are grown in a human body, which is very, very reassuring. But we can put this added assessment if we need to, or if you want to, or we think it's in your best interests, so we can genetically assess. So we're not just looking at the morphology, what they look like. We're not only looking at how quickly they've grown, but we're actually looking at the chromosomes inside the embryo. So we can say this is a genetically normal embryo, or this is a genetically abnormal embryo, which is not compatible with life. If all embryos were normal, we get pregnant all the time. But as in natural conception, not all embryos are normal. And unfortunately, embryos become more abnormal the older we get. So when we reach the age of 40 years, 75% of all the embryos we create are genetically abnormal. Next slide, please. So what we can then do, once we've got our embryos to 5 days, we can either put one embryo back fresh, or we can freeze the embryos. And we can, we put the embryo, we do something we called in vitro culture, where we can actually, we actually desiccate and slowly freeze the embryos down to, I think it's minus 180 degrees centigrade. We can safely keep them for many years. And when it time that you might want them back, you know, you might decide to freeze your embryos and recover from the egg collection, or you know, if there's a life event, you might say, well, look, I'd like my embryos back at Christmas or in January or in March. We can then thaw them out at a time which is convenient for you and put them back. And the thaw rate, the success of thawing is 99%. For every 100 embryos that we freeze, 99 will thaw safely. Now, again, because I'm old, I can say this. If I was saying this 30 years ago when we first started, it would be less than 50%. Less than 50% would thaw safely. So we always try to put embryos back fresh many years ago, because we couldn't freeze them successfully. Because we couldn't freeze them successfully, we used to put back more embryos, more than one embryo at a time. And that bore the risk of multiple pregnancy. Now, you know, if you've been trying for a baby for years and years and years, often the idea of twin pregnancies is a nice idea, but twin or triplet pregnancies are fraught with danger for the mother. They miscarry much more often. They're born prematurely, and twins can often suffer significant illness as a consequence. Obviously, we see lots of healthy twins being pushed around Aldi or Tesco's or wherever, but we never see the ones that are ill, that have miscarried, or that have been not been born alive. So what this allows us to do is we can put one embryo back safely. The pregnancy rate is good, and your chance of a live birth of a healthy baby is much better. So I say to patients, have as many embryos put back as you want, one at a time. If you've had your embryo biopsied, then for PGTA, then you have to freeze it, because we don't get the result for 2 weeks, and an embryo won't live for 2 weeks. Some people want to have their embryos put back fresh. There's no necessary advantage of putting an embryo back fresh, except of course you get pregnant. If you are going to get pregnant, you'll get pregnant quicker. But most people nowadays prefer to have their embryos created and then frozen and kept for another day, maybe after 2 or 3 months, and then have your embryos put back in a non-stimulated cycle. Okay, next slide, please. And then when we put the embryo back, we call that the embryo transfer. So if you're having your embryos put back fresh or frozen, the process is very similar. We take you come in to the clinic. It takes about 10 minutes to do. It's done with no, in the vast majority of cases, you don't need sedation. It's a bit like the equivalent of having a smear, and the embryo is loaded into a very fine catheter. Just like you have it when you're having a smear, the speculum is put in, and the catheter is then slid in through the cervix and into your uterus, the womb, and the embryo is very safe, very carefully deposited into the upper part of the uterus. And we use ultrasound guided, in most cases, ultrasound to give us an idea where the embryo is going to be placed. We don't do it in everybody, because some doctors prefer what we call the no touch technique, or where we don't need the ultrasound. But the most times it's actually nice, because you actually get to see where your embryo is going. Then after the embryo transfer, you can get up straight away. You don't need to lie down. You don't need to rest, because if you think about it, the embryo at that particular point would sit on the sharp end of a pin. That's how big it is. So when you stand up after an embryo transfer, it's a bit like, you know, a bottle of pop. If you turn the bottle of pop upside down, the bubbles go to the top. So when you stand up, your embryo floats upwards. It doesn't fall out. It goes upwards. So I encourage my patients to stand up and mobilize. And when you then go for a wee after you've had your embryo transfer, the bladder is below where we put the embryo. So if you think about it, when you empty your bladder, the embryo gets pushed even further up. People think, oh, I can't have a wee because I'll wee my embryo out. No, you don't. It actually pushes the embryo back up. And then after your embryo transfer, you go home, and I've got no solution for this, but we then have to wait 2 weeks. It's the 2-week wait. And I wish I knew what the formula is to help people relax and not anticipate what's going to happen to them, because it's a very anxious time. But all I can say is be yourself. Don't lie down and do nothing. Don't go skydiving or scuba diving or something like that. Just be your normal self and go about and keep your embryo, keep your muscles pumping and keep the blood flowing to your uterus, and just try and avoid life event. You know, some people say to me, oh, you know, after an embryo transfer, we're going to move house, or we're going on holiday, we're going trekking in the Himalayas. Well, you know, why do that? Or it's like other people, you know, when you go, I want to go to Morocco for my holidays. You've been trying for a baby for 10 years and you've just got pregnant, and you know, just stay at home, do normal things and chill out. But don't just lie in bed and do nothing. Okay. Next slide, please. IUI is another treatment. It's a popular option considered by many groups. It's a treatment is called IUI, is intrauterine insemination. We use it for sperm donation in same-sex couples, where we use donor sperm, and it's where we prepare a sample of sperm and inject it at the right time in the woman's cycle, right up through the cervix into the uterus, a bit like an embryo transfer, only without an embryo and with sperm. And we usually use it for unexplained infertility, for donor insemination in same-sex couples. But it's a popular process, and in the right people, the right diagnosis, it's a successful treatment. Intrauterine insemination. Next slide, please. There are also for same-sex couples, we can, depending on the couple's wishes, we can do shared motherhood, which I find really cool, because it's where we take the egg from one parent, we fertilize it with the sperm of the donor, and then we put the resulting embryo into the other parent, so that one half of the couple is the genetic mother and the other half is the birth mother. So it's a program that a lot of my same-sex couples like, but again, it's you know, families for everybody. What's good for other people, some people, is not acceptable for others. So all these things can be talked about at length with your clinic consultant or the nurses, and we have experts. Fortunately, we've got such a big network. We have over 80 consultants. We have well over 100 specialist nurses, so we can, we can consult with each other. We meet on regularly to discuss difficult cases. I personally love the idea of shared motherhood, but that's my opinion. It's not for everybody, but it is for a lot of our same-sex couples, particularly in Liverpool. Next slide. There are some couples who need donation. Either in the case of women, they may have a reason why they have they've exhausted their egg supply. It might be due to age, or it might be due to a genetic abnormality, or something called premature ovarian failure, where for some reason or another the woman just does not have any eggs, in which case we can use a process called egg donation. So we get a potential donor who will donate their eggs on behalf of the recipient. We have a large donor bank at Care Fertility that we can resort to, and similarly, if we don't use our own egg bank, we have access to lots and lots of other egg banks. Similarly, if in single women or same-sex couples, or heterosexual couples where the sperm count is of the male is negligible, we can use donor sperm. And again, we have our own sperm bank, but we can also use the European Sperm Bank, Fairfax Cryobank, there's the London Sperm Bank, and we match the donor for colour of hair, size, colour of skin, colour of eyes. We can go through that in detail. Anybody who requires donation has to think a little bit more carefully about their proposed family, but we are there. We have specialist donation nurses, we have specialist donation doctors who can, and of course counsellors who can take you through and be with you every step of the way. We know that, not only does an inability to have a child do your head in, but the treatment can do your head in as well. But so the most important thing for me is to have support from your clinic, from your friends, from your doctor, every step of the way. We can't get it right all the time, but I like to think that we get it most of the time for you as an individual. Next slide, please. Just a bit about ourselves. What I've said, our success rates are exemplary. We have one of the leading egg banks. You can choose frozen eggs or fresh eggs. Quick and easy access to treatment when using frozen eggs. All our donor egg treatments take place in the UK. So if you're uncertain about getting treatment from abroad, that in some cases can add to your anxiety, well, we're on site. But of course, you can discuss all these things at your clinic before you make any decisions at all. Next slide, please. Oh, what's this? National surrogate. Oh, yes. So, of course, we not only deal with people who may have difficulty conceiving because of lack of sperm or eggs. There are some cases where we don't have a uterus. Either the potential mother's uterus has been removed through disease, or cancer treatment, or radiotherapy, or indeed there are some cases where women are born without a uterus, in which case we need to support that couple and find what we call a surrogate, where a woman is willing to act as a surrogate mother on behalf of the commissioning couple, whose embryo is then placed into the surrogate's uterus, and she grows the baby on behalf of the commissioning couple. Again, that can be fraught with complications if not done in an expert centre. And again, we have dedicated and designated surrogacy experts who can support you and, importantly, advise you if you're thinking about or you think you might need surrogacy. And last year we were the winner of the National Surrogacy Awards. Care Fertility was the surrogacy clinic of the year. So we were very, very proud to receive that award. Next slide, please. So this is getting a bit complicated, but very briefly, in host surrogacy, the baby is not related to the surrogate mother, an intended parent or mother-to-be, and the intended parent and mother-to-be can donate her own eggs for conception, and the surrogate carries and gives birth to the baby. Or in direct surrogacy, an egg from the surrogate mother is used alongside sperm from the intended father. So in direct surrogacy, then the surrogate is the biological mother of the baby she's carrying. She's provided the egg. Okay, but of course, these are all very complex issues that we can go through in fine detail if you think that you are one of these potential people who might need surrogacy. Next slide, please. As I said before, we are not only here to provide the treatment, but we recognise that surrogacy, egg donation, IVF, and indeed all aspects of infertility can be very stressful. So not only do we have people on call ready to answer any of your queries or address your anxieties, we've also now got an app, Salve, which provides information regarding your medications. It keeps you track of all your appointments. You can chat with any of our team. You can digitally sign consent forms, which can be a pain, but so anything that makes it easier has got to be better. You can pay your invoices if you are a private patient and you're not an NHS patient. You can learn more about the medications and procedures. And of course, you can share your treatment plan with your partner, which is always got to be a good thing. So the Salve app is now coming. It's been rolled out in 2 or 3 of our clinics, and we're now moving into hopefully all of our clinics very shortly. And it's received very positive feedback from our patients. Next slide. So for those of you who are not eligible for NHS treatment, and that in itself is a whole different program or chat, so I won't go through that at the moment. For those of you who have to pay, we've got lots and lots of payment programs. We used to do our own payments for ease of access and simplicity, and keeping out third parties, which might made things more complicated. But we now have buddied up with a company called Care Fertility, who can offer interest-free credit. But we've also in collaboration with Access, designed payment programs which offer a refund program, a multi-cycle program, a donor egg refund program. So every single payment program has a different positive and negative. So why choose a payment program? Well, for example, multi-cycle packages at a fixed discounted price. Some offer a 100% refund on your treatment. And as I said before, we've got interest-free credit options that are available. So, you know, what we're trying to do is to make your choices and take out a bit of the anxiety, hopefully a lot of the anxiety, out of aspects of the treatment that can be confusing, complex, complicated, so that your journey through the IVF process can be as painless as possible. Next slide, please. What we've also done, which we've found due to patient requests, is that we're now offering full fertility checks for you. Some people just want to know, just for their own reassurance. They may not be trying for a family. They just want to know what their fertility is likely to be. Of course, you can never fully assess your fertility until you've had a baby. I know that sounds a bit obvious, but what some tests can do can point you in the direction to give you reassurance that on the face of it everything is normal. So for this price now, I'm not really a salesman, so this is a bit difficult for me, but I'll do my best. For £449, you get an ultrasound scan, the semen analysis, the anti-malarian blood test, and you get initial consultation with one of our consultants to go through the tests. As I said, there's millions of tests you can have, but some of them are of more use than others. These are the tests that are absolutely essential. Other tests may be of interest, but they ain't essential. So these are the ones that you need to know. Are all my bits in the right place? Is my partner, if you're in a heterosexual relationship, is my partner's sperm count normal? And is my egg count normal? And I know that my daughter's just been through one of these because she's 33. She's not thinking about having a family yet. She's got, you know, other things that she wants to do in her life. So for reassurance, she said, Dad, can I just check these things through? And for 450 quid, she's now got the reassurance that her AMH is normal, and a partner's semen analysis was normal, and a scan's normal. Oh yeah, there we are. Look at that. Our full fertility check is it's an assessment, and I think if you just press on that, Sam, is that right? That you can enrol for your fertility check if you so wish. Next slide, please. As I said, what we aim to be is to be there for you every step of the way. IVF, infertility, can be a very nerve-wracking situation, sometimes compounded with what you read on social media, and some of the stuff I read nowadays just makes the mind boggle, because it 9 times out of 10 it overcomplicates things. IVF infertility, as I said, hasn't changed an awful lot over the past 40 years. Tests and laboratory innovations have improved massively, like we've just discussed. But I want you to be able to get a clear path to know what's right and what's best for you, and how we can support you. You know, from the car park outside to knowing who you are on the inside. It might be that you want to go to a massive clinic in a big teaching hospital, or for you as a couple or as a single woman, you want to go to a small clinic just down the road. But whatever you want, whatever you need for yourself, we will do our best to try and support you in your journey. So at the end of the day, you can say, I've done my best, and we can say that we have done our best for you, and then hopefully we get the result that we want. Next step, please. So here we are to these are the sort of things that we can offer at Care. We've got a new patient inquiry team. We've got the patient resource hub. We've got Care Pals. These are our staff on the end of a phone who can help to support you, answer queries, point you in the right direction. We've got our Care Forum on hopefully on Salve coming soon. We've got our counsellors if you feel that you want to talk to somebody over and above your friends, or who you might feel as though that it's too intimate or too personal, that you want to share with members of your family. And some, most of the time that's the case. We can provide independent counselling for you. And we're on social media, Facebook, YouTube, all that sort of stuff. And hopefully that we can support you on that. Let me reassure you that no question is too daft. I have heard over 35 years some of the daftest questions you'd ever, but I bet you a bottom dollar I've heard dafter questions than the ones you want to ask. So please don't feel, because we've all got, we all think that we don't know something and we want to ask a question. And I know this sounds a bit silly, Professor Kingsland, but I bet you it's not. And we're here to answer those questions because that's what we do. So any questions? Now, I think, Sam, if you've got 5 minutes, I'll just go through as many questions as we can. So if you could just, is the same price of the fertility test? You've answered that. Yeah, there is. Even if you can get NHS funding, get these done, tested. Yeah, knowledge is power. You can't. Yeah, that's a good question. Are there any questions that we need to answer? Sam, do Care Fertility have the expertise to work with sperm issues? My husband had an SSR via so here we have do Care Fertility have the expertise to work with sperm issues? My husband had a surgical sperm retrieval. We've been advised to find a clinic that have experience in working with sperm retrieve via this method. Of course we do. That's what we do. We're a fertility group. All we deal with is fertility issues. So we have expertise in surgical sperm retrieval. Yeah, of course, we can help with that, and hopefully we can help locally. I don't know where you live, Lauren, but we should have a local clinic who can support you and sort that out for you. I had my eggs frozen in Spain, as I am Spanish, but I've been living in the UK for many years and I'm settled here with my British partner. How difficult could it be to bring my frozen eggs to the UK to Care Fertility because of Brexit? It actually is quite difficult to get your frozen eggs over, Paula. However, we have excellent clinics in Spain, and just as an example, I often find that it's cheaper it's quicker to get to our clinic in Alicante from Liverpool. There are 3 flights a day to Alicante at 40 quid on EasyJet, whereas a trip from Liverpool to London is more like 250 on the train. So I'm not suggesting that's what you should do, but what I am telling you is that it is difficult to import frozen eggs in some circumstances. So check with the local clinic, have a chat, and if necessary, we can organise you to sort out your treatment actually in one of our clinics in Spain. So let me just have a look. It can be really scary. I think, what are the advantages? What are the advantages and disadvantages about having implantation with fresh and frozen? Hopefully, I've covered a few of those, Paula, today. Having a fresh embryo transfer, that's usually 5 days after your egg collection. You may not feel in the right space to have your embryo put back, or it may be that you want to get pregnant quickly or get all the treatment out of the way. Similarly, what I would prefer personally is to get your eggs collected, get your embryos created and frozen. You go away, you can chill out, you can recover from the stimulation and the egg collection, and then come back at a time that's more convenient, more suitable for you to have your embryo thawed and put back. Everybody's different, but the best thing to do is to have a chat with your local clinic, and then hopefully you'll make the right discretion. I'll pass your question. What's this one? If you've had eggs frozen and defreeze, I had OHSS before. Is there anything I can do to prevent it this time? Now, OHSS is one of the risks that you get with IVF. Fortunately, it's very, very uncommon, or it's where your ovaries react very, very vigorously and unpredictably to the stimulation drugs. OHSS stands for ovarian hyperstimulation syndrome. And so your ovaries go mad. You can produce lots and lots more eggs than we anticipate. Instead of getting 10 or 12, you get 20, 30, 40, or 50 eggs. And that can lead to significant problems: bloating, nausea, vomiting, biochemical abnormalities, clotting. So we try and avoid that at all costs. Sometimes it's unavoidable, but if you've had OHS before, Stacey, you'll probably know that it's not very nice, and there are lots of things we can do to prevent it and negate it altogether. So your doctors or your team will be onto that, and I would suggest that you get a consultation with them. How much is the IVF altogether and medication? It's different for different people, but if you phone your local clinic, they can tell you exactly how much it will cost. And this is a tip from me: don't start your IVF until you know exactly how much it's going to cost you, because we get I get a lot of patients asking me, well, I didn't think it was going to be that. I didn't think there was going to be cost for that. Ask all the questions and say, how much is it going to cost? What is the final cost? And even if there are bits that you might not anticipate at the end, at least have a range so you know it is not going to cost you a penny more than X £1,000. So at least you can budget, and hopefully with our care pay programs, they can fit your requirements. So before you start, you know, how long am I going to devote to this treatment? It might be 6 months, it might be 2 years, but you're in control. How long am I going to spend undergoing this treatment? How much is it going to cost me? And what are my chances of success? And we should be able to tell you that. And then you can decide with all the information in front of you, it's going to cost £10,000, it's going to take 2 years, and your chance of getting pregnant is 70%. Something like that. Everybody's different. You ask for that information before. So I think we've been going an hour now, and I bet you I'm boring some people to death now. So I'm going to finish there. Most of the questions have been answered. If you have any further questions, our team can get back to you. And as I say, any queries, anything about your fertility MOT, just contact the care helpline, your local clinic, and we are there to help you. So I hope you found that last hour helpful. All you need now is a bit of luck and chill out. And thanks for listening. Bye-bye, everybody.